Thank you, Mr. Chair, and I'd like to introduce myself, if I can, even just for a minute. I am a son of the Valley where I was born and raised in the central San Joaquin Valley, and I made it my goal in life to return and to take care of my people and my patients in my valley. I have worked for the better part of the last decade in an emergency room where I take care of everybody who walks through my doors, and I am proud to do so. But I have seen the inequities of our healthcare system and am frankly disgusted a bit by the policies that we have, and we must find ways to start to fix a broken healthcare system. What I would like to do, and what the Latino Caucus has asked me to do today, is to come to ask for funds so that we can start to evaluate and provide numbers and metrics to evaluate how we have these inequities. Specifically, in my community, we have African Americans who have higher rates of infant mortality than many third world countries. We have Hispanics, Latinos, and Latinas who are having nearly double to triple the amount of amputations due to preventable causes of diseases like diabetes. I would like us to start to evaluate what metrics and numbers we need, such as we have in Covered California. I believe that Covered California is leading the way. And I would like to make sure that Medi-Cal is following suit. And so I would ask humbly this chair for $200,000 so we can start to evaluate what specific metrics we have and whether or not there are inequities within our system.
I want to thank Assembly Member Arambila for your compassionate and compelling testimony. And I'll just say that I appreciate your focus on equity. And it is one of the themes that we have maintained here in Sub 1 and will continue to do so. We're not agendized to be able to take action today, but we appreciate the context that you've given this from a level of expertise that only you might know from your role as a physician who's worked and served communities whose needs have been significant. And as your colleague and as a member of the Latino Caucus, I appreciate what you have brought forward on behalf of the caucus and the people of California. And this committee welcomes you anytime that you want to share your insights and your expertise here in Sub 1.
Thank you, Mr. Chair.
Thank you. I understand that you have some others co-presenters who would like to add more emphasis on the proposal. We welcome you.
Thank you so much, Chair and members. Michelle Cabrera with SEIU California, and we are in strong support of the Latino Caucus proposal to align Medi-Cal with the recent actions taken by Covered California to move to 80% self-reported race and ethnicity data by 2019. The impact of this is that we will both have Covered California and Medi-Cal be on the same page about how we collect data about race and ethnicity, so that we can then take actions to hold plans and providers accountable for both identifying as well as reducing health disparities. As the member stated so well, we know in the aggregate that disparities exist. We know that they're out there. We're just not holding plans and providers accountable. And Medi-Cal has a huge opportunity to do that. People of color are overrepresented in Medi-Cal, and so it can really work as an active purchaser, as Covered California is doing. And for those reasons, we're in strong support.
Thank you.
Kimberly Chen with the California Pan-Ethnic Health Network, also very much in strong support of this proposal. CPEN's mission is to advance health equity and to reduce health disparities. So this fits very squarely within our work, and very much appreciate the Assembly members' passion for this issue and the caucus's proposal. Given that Medi-Cal covers almost a third of Californians and that people of color are the majority of them, this proposal will go a long way, especially given the tremendous churn between the Medi-Cal and Covered California population. This alignment would help purchasers ensure that both systems are putting the same emphasis on disparities reduction. So we're very much in support.
Thank you. Ms. Cantwell, did you have anything that you wanted to add?
Nothing specific to the proposal, but just to note that we did amend our contract last year with our external quality review organization that conducts our independent review of plans, quality, and the HEDIS measures. And so this year, for the first time, later this year, we'll be reporting the HEDIS measures that will be stratified by various demographic factors, including race, ethnicity, language, gender, age, and geographic area.
Thank you. Is there anything from finance?
We have no position.
Anything from the LAO's office? Thank you. We'd like to hear from the public. Any public comment? Please proceed.
Sure. Mr. Chair, Tam Ma with Health Access California Support.
Linda Way with Western Center on Law and Poverty in strong support.
Good afternoon. Alice Kessler on behalf of Equality California. Just to note quickly, we've been working with the state to include sexual orientation and gender identity in the state's data collection, and at the plan level, that'd be very helpful moving forward as well. Ask for your support.
Thank you.
Pashi Michelson Walker, NorCal Mental Health America, and the director of the Phase 1 of the California LGBTQ Reducing Disparities Project. This was our #1 recommendation, including the intersection of racial and ethnic identities within sexual orientation and gender identities. Strongly support.
Thank you.
Christina Romero, Planned Parenthood Affiliates of California, representing over 115 clinics across the state. This data collection is extremely important to us as healthcare workers, and we strongly support the budget proposal.
Thank you. Any other public comment? We thank all of the speakers. Again, as we're not agendized for action today, but I would say that this committee has demonstrated its support for disaggregation of the data. Many of us who have spoken out both on the policy level and in other ways in the community to support that. And so, again, we appreciate all of the advocates and partners who are here today, and we appreciate you, Dr. Assemblymember Arambula. Did you want to have any closing remarks on the item?
No, thank you, Mr. Chair. Thank you.
Thank you. Thank you very much. We're going to move to issue 16, and it is the Emergency Medical Services Authority. Related to Emergency Medical Services Authority, issue 17, we have a department overview, and we also have a member who is going to speak on behalf of a proposal. Excited to see Assemblymember Rodriguez here. I want to welcome him to come forward, and we'll hear from the department as well. Welcome, Assemblymember. We defer to you if you prefer to have the department give an overview and frame, and then you can add context on the proposal, or if you wish to frame the issue directly.
However you see fit, Chair.
We defer to you.
Your
sir.
disposal.
You are our guest. We defer to you.
Okay. Well, thank you very much, Chair. As you know, as a first responder for over 30 years, and I've seen that the greatest need is protecting the lives of Californians. So I'm here respectfully asking for a $2 million allocation to the EMSA budget for the upcoming 2016-2017 year. As you know, the 3 mobile field hospitals we have currently are mothballed here near Sacramento, and each one has a capacity of treating over 200 patients. I feel that $2 million is a small investment in Californians. We've been lucky so far that we haven't had a major disaster that we would have these, that we need them. But unfortunately, as time has went, we need to maintain these mobile field hospitals to make sure they are readily available for Californians, because as we all know, California is prone to disasters, fires, floods, and earthquakes. And this is just a small investment, like I've said, that protect Californians. So I'm here asking for the consideration of $2 million to appropriate to EMSA's budget to hopefully fund these, maintain them, and transport these mobile field hospitals. Thank you.
Thank you, Assemblymember Rodriguez. We appreciate your expertise, and you have direct knowledge in this area. while we're not agendized to take action today, it is important to us, and that's why we wanted the committee to hear it. I can also share with you that when we had this presentation last year, we had a very robust discussion about the mobile fuel units and what it would take to get them functional again, as you say, to prepare for natural disaster and to be ready. So we appreciate your leadership on this subject and pushing us to make sure that we are as prepared as we can be in the event of any disaster.
Thank you.
Thank you, Assembly Member. We welcome hearing from the department, your overview, and we'll move to any questions that may come from there.
So you'd like to at this time hear the departmental overview? Okay. Thank you, Chairman Thurman. Chairman and committee members and Andrea, I'm Dr. Howard Backer, Director of the Emergency Medical Services Authority, which I'll refer to as the EMS Authority, and this is Dan Smiley, our Chief Deputy Director. First of all, just a note on our governor's proposed budget for 2016-17, which released in January of this year, includes expenditure authority in the amount of $36.1 million and 66.9 permanent positions. And of this, 42% is delegated for state operations and 58% is delegated to local assistance. As you know, we do not have any new workload or policy adjustments under consideration at this time. Our EMS system in California was created in 1981 by the Health and Safety Code Division 2.5 with the intent of creating a statewide system with the EMS authority responsible for the coordination and integration of all state activities concerning emergency medical services and to ensure the provision of effective and efficient emergency medical care. And emergency medical services are broadly defined as the services utilized in responding to a medical emergency. We're a small department but have a large mission, and our responsibilities fall into three categories. First, pre-hospital emergency services, which is one piece of an emergency care network integrated with hospital emergency departments and other services that provide a major healthcare safety net. Our pre-hospital 911 is particularly or widely seen by the public as a guaranteed medical service that's coordinated by local government. In California, there are 60,000 certified EMTs and 21,000 licensed paramedics that respond to about 4 million 911 calls for emergency service annually, with 3,600 ground ambulances and 50 air ambulances. And they generally take patients to one of 306 acute care hospital emergency departments, which may be a designated specialty center like a trauma center. Specifically, we are responsible for a scope of practice, training standards, regulations for the practice of pre-hospital care, both provided by EMS personnel and public safety personnel, and that includes tactical first aid. We also license paramedics and discipline the licenses, and we oversee public first aid standards, training and regulations related to licensed child care providers and specific medical interventions for the public, such as epinephrine for allergic reactions, naloxone or Narcan for narcotic overdoses, cardiopulmonary resuscitation, and automated external defibrillators. One important initiative from the EMS Authority regarding the role of paramedics is an approved health workforce pilot project through the Office of Statewide Health Planning and Development to test and evaluate the use of paramedics in expanded mobile health care roles that fill some of the gaps in local health care systems and improve access to care and integration of care. And some of these projects being tested include the use of paramedics for post-discharge follow-up to prevent hospital readmissions, managing patients who frequently access 911 and emergency department services by linking them with social and other health care services, and taking patients to alternate destinations other than emergency departments, and working with hospice nurses to prevent unwanted emergency department visits at the end of life. Second, as is with many other state programs, the EMS system is a two-tier responsibility between state and local agencies. So we develop guidelines and approve plans for emergency medical systems that are implemented and operated by the local EMS agencies. There are 33 of these agencies. Direct 911 ambulance services provided by a mixture of public and private providers. And in this oversight role, the EMS Authority also provides operational and quality parameters for the local EMS agencies and provider agencies, and we develop regulations for the specialty care systems that include our trauma system, our pediatric emergency care centers, our stroke centers, our cardiac centers, and poison control. One of our priority initiatives is to assess the effectiveness of the EMS system by using improved local and regional data. AB 1129, chaptered last year, requires EMS providers and agencies to document patient care in electronic records that can be aggregated, analyzed, and used for system evaluation and improving patient care through performance improvement. We're also working to exchange clinical data with hospitals so paramedics can have patient data in the field. And then that initiative will also improve care during a disaster by making critical patient information available when patients are treated in different systems. And finally, pertinent to this discussion, our third major area of responsibility is medical response to disaster. And the Health and Safety Code mandates that, in cooperation with the Office of Emergency Services, that we shall respond to any medical disaster by mobilizing and coordinating emergency medical services, mutual aid, and resources to mitigate health problems. So we partner with the Department of Public Health to build a public health and medical response infrastructure and to plan for the medical impact of disasters and major events, from earthquakes to air crashes to pandemics and heat waves. At the core of our preparedness is a staff trained in emergency management and in our response plans and tested and trained through exercises and events. But we've developed a tiered response to disasters, the first tier being 42 ambulance strike teams that are housed in local jurisdictions and can establish field triage, treatment, and staging site for multi-casualty incidents within an hour. These are routinely used by local jurisdictions for multi-casualty events and for hospital evacuations. Second tier is our California Medical Assistance teams, and I've already mentioned these teams in our prior testimony. And these are one of the most flexible direct patient care assets because they can be deployed as a team of any size and take on health missions from acute emergency care to management of evacuated long-term care patients. The third tier is our mobile field hospital program, and currently all three of these hospitals are stored without equipment maintenance and would require several weeks to deploy. We have attempted, as you can see, to develop a broad and flexible medical response capacity to address all types of disasters. We have also widely discussed the capabilities and uses of the mobile field facilities, and that we do not have funds to maintain them. The level of preparedness for a catastrophic event for which these would be used and the balancing of funding priorities is a decision, however, for the legislature and the administration. I stand open for any questions.
Thank you. Is there anything from finance? Anything from the LAO's office? Any public comment on this overview or on the proposal? Seeing none, thank you for the presentation, and thank you, Assemblymember Rodriguez. Did you want to have any closing remarks on the proposal?
Yes, just to say a little bit of the history with emergency preparedness and response. I look back on my experience as being a first responder in Hurricane Rita and Katrina in Louisiana, where we thought as a nation, as a state back then, that we were prepared for a disaster. Well, let me tell you, when I was there the first week, we were total chaos. Nobody knew what was going on. The state, our nation, thought we were prepared for that. And one thing that's always stayed in my mind till this day, I was there for 4 weeks. The last day I left, the emergency responders there in Louisiana said, Freddie, we're going to see you in California when you guys have your big disaster. And that's always, I go, you know what, you're right, because it's just a matter of time before we have a disaster strike us here in California. And when I found out that we had these 3 mobile field hospitals and they're not in condition to be functional, I think it's just a misuse of taxpayers' dollars. When we bought these hospitals 10 years ago, whatnot, for I think $20 million, and to see that they're being mothballed in a storage area is wrong. So I just want to make sure that we realize that we have these capabilities of 3 mobile field hospitals for us here in the state of California when that disaster happens, that we're prepared to respond and take care of the people in the state of California. Thank you.
I want to thank you, Assemblymember Rodriguez, for making the call for us to be prepared. And as you say, to not sit on resources that would be critical in a critical situation. I want to thank you for sharing your expertise with the committee, for your leadership, and being an important voice on these issues that often don't get raised. And so we look forward to the ongoing conversation. And thank you for what you've done in communities like where Hurricane Katrina have hit, and for helping us to be prepared here in California.
Thank you.
Thank you, Assemblymember. Thank you all.
Chairman, I was asked to comment on one other issue that is pertinent to emergency response, and that was the San Bernardino response. Do you want to continue and do that?
Please.
So we were asked to comment on EMSA, whether the Emergency Medical Services Authority played a role in the response to San Bernardino. And we did not play a role in the initial emergency medical services response to the San Bernardino terrorist attack. That was managed at the local level. However, our public health and medical mutual aid system, that is led by the Department of Public Health and EMSA, worked to support resource requests for San Bernardino. The EMS director in San Bernardino served as the Medical and Health Operational Area Coordinator, and our Regional Disaster Medical and Health Specialist and Coordinator for Region 6, coordinated resources from neighboring jurisdictions. Initially, 3 ambulance strike teams from Riverside County were mobilized and staged for the event. One functioned as backup in San Bernardino for the local EMS agency to cover calls in the community while their ambulances responded to the event. The major resource requests involved personnel to carry out the environmental health functions for a decimated and traumatized program. The other main need was for behavioral health resources to analyze and support the community needs and plans for long-term recovery. This resource discussion also involved our federal partners. So to date, there have been 17 resource requests for these various personnel that have been handled by our Regional Disaster Medical and Health Specialist and filled from mutual aid regions 6, which includes San Bernardino, Riverside, Region 1, which includes Los Angeles, and even Region 2. So it was a nearly statewide response, but it was coordinated from the local regional level with minimal need for support from the state. And then the last thing that Dan Smiley mentioned was in compliance with AB 1598. In fact, Assemblyman Rodriguez, we were working with law and fire and first responder organizations to develop training standards for the medical support of tactical teams who respond to these events.
Thank you. Thank you for your presentation, and thank you again for your leadership, Assemblymember Rodriguez.
Thank you.
We're returning in the agenda to managed care issues. We're at issue 6, infrastructure and support services budget change proposal. Looks like we will have a number of presenters from the Department of Managed Health Care, Finance, and LAO's office, and then public comment.
Thank you, Chairman. Again, this is Marta Green, Chief Deputy Director here at the Department of Managed Healthcare. Issue 6, Infrastructure and Support Services, BCP. The DMHC has experienced rapid growth since the enactment of the Affordable Care Act. In the past 5 years, the DMHC has added more than 90 program positions, which represents approximately 26% growth in our department. At the same time, the department was granted only one additional administrative services support position. As such, the DMHC requests 2 permanent positions and $247,000 for fiscal year 16-17 and $234,000 for fiscal year 17-18 and ongoing to address increased workload resulting from program expansions attributed to the implementation of the Affordable Care Act and conforming state legislation. Okay, so issue 7. Oh, no, that was it.
I just meant if you had anything else on issue 6.
Nope.
Thank you. We like that you're moving ahead. The chair appreciates brevity
she's very
and
efficient.
moving ahead. Did you want to add anything?
I was just saying she's very efficient.
Okay. Is there anything from Finance and from the LAO? Any public comment on issue 6? As you said, Ms. Green, issue 7.
All right, issue 7, large group rate review. Senate Bill 546 established additional rate review requirements for the large group market. Effective on or before October 1st of this year and annually thereafter, health plans must file additional aggregate information regarding all of their large group products. Currently, there are 19 health plans participating in the large group market. The DMHC requests 4 permanent positions and $682,000 for fiscal year 16-17 and $644,000 for fiscal year 17-18 and ongoing to address the increased workload resulting from the implementation of this bill. This request includes $106,000 for fiscal year 16-17 and $100,000 for fiscal year 17-18 and ongoing for actuarial services to support the DMHC's review of the filings.
Anything else from the department?
Yep.
Anything from finance, from the LAO's office? Public comment.
Mr. Chair, member Sarah Flox from the California Labor Federation. We were one of the co-sponsors of SB 546. This is an important bill to bring more transparency to how premiums are set for large purchasers and those in the large group market, and we very much support this proposal. Thank you.
Thank you.
Beth Capel on behalf of the Teamsters and Unite Here, the co-sponsors of this measure. Only in this country would the Teamsters and the hotel workers have to co-sponsor a measure on rates to large purchasers. We look very much look forward to the first public meeting in which we'll get to discuss the outrageous health plan premiums we are charged. Thank you.
Thank you.
Tam on behalf of Health Access, which supported this bill, and we're here to support the BCP.
Thank you.
Michelle Cabrera on behalf of SEIU California, also in support.
Thank you. Any other public comment? Bless you. We are moving on to issue 8. Limitations on cost sharing, family coverage, AB 1305 budget change proposal.
All right, thank you. AB 1305 makes 2 changes to existing law. For non-grandfathered family coverage, this bill prohibits a health plan from imposing a maximum out-of-pocket limit for an individual within a family that is greater than the maximum out-of-pocket limit for self-only coverage for that product. Also for non-grandfathered family coverage, this bill prevents individuals within a family from having a deductible that is greater than the deductible for self-only coverage for that product, except for a high-deductible health plan. To implement this bill, the DMHC requests limited-term resources of $196,000 for fiscal year 16-17 and $188,000 for fiscal year 17-18. These resources would enable our department to promulgate a regulation that will provide clarification and guidance regarding the tracking of accumulation of enrollee cost share, and the regulation will also clarify allowable out-of-pocket maximum and deductible limits with respect to high-deductible health plans.
Anything else from the department? From finance? From LAO's office? Public comment.
Tam Ma with Health Access California, the sponsors of the underlying legislation. We support this BCP, and we look forward for the stakeholder process to begin to implement this bill.
Thank you.
Linda Way with Western Center on Law and Poverty. We supported the legislation, so also support this BCP.
Thank you. Any other public comment?